Hello, everyone. Welcome to MECCA Moments. It's Friday, September 25th. Today is National Day of Remembrance for Murder Victims. Let's start with a moment of silence for Breonna Taylor and all those who were unfortunately killed by others. A great show today. Today we're talking about maternal mental health. We have Dr. Banks, of course, and Siobhan Odo. Welcome, ladies.
Welcome. Hello.
Dr. Banks, can you introduce our guest today?
This is certainly
Today is National.
Certainly a pleasure to introduce one of my former students, a great scholar that graduated from Howard University with a degree in counseling psychology. She earned her master's while studying at Howard. She is now a licensed professional counselor in Washington, D.C. and Maryland that is certified in perinatal mental health counseling. She is the owner of her own private practice, Acoma Counseling Concepts. She specializes in counseling mothers with perinatal disorders such as postpartum depression, fertility issues, miscarriage, and postpartum anxiety. Welcome, Siobhan.
Thank you. Thank you.
Welcome, Siobhan. So we're talking about maternal mental health. And Dr. Banks mentioned some of the things that you specialize in, but for our audience, what is maternal mental health? What does that encompass?
Sure, that's a great question. Maternal mental health encompasses counseling for individuals who are struggling with perinatal mood and anxiety disorders like postpartum depression, postpartum anxiety, postpartum PTSD or postpartum post-traumatic stress disorder, postpartum obsessive compulsive disorders, or individuals that are also trying to navigate the waters through fertility, through infant loss, through pregnancy loss, and also through adoption.
Okay. Well, let's start with postpartum depression. I know that's become something that we've been exposed to a lot more in the last 5 years. Can you explain what actually is postpartum depression?
Sure. So postpartum depression is a type of depression that occurs during the perinatal time period. And perinatal includes pregnancy up until when the baby is 1 year old, or for those individuals that did not deliver a live infant, you can still struggle from symptoms of postpartum depression up until 1 year of the pregnancy loss. And so the symptoms can include mood swings, irritability, appetite loss, extreme decrease in sleep, which sometimes can be very tricky because it's, hey, this baby is on this sleep schedule, or if a mom happens to be breastfeeding, they have to be up once every 2 hours to feed the baby. So that can be really tricky to kind of be able to determine, hey, I only got 4 hours of sleep total, and that's just not okay. But that's one of the symptoms that come along with it. Also, rapid weight loss. Also, I'm trying to think. It spreads like so. It varies so much. But I see sometimes I tell people some of the angriest moms that you have met are some of the most depressed moms. And you do not have to be a woman to have postpartum depression. As a matter of fact, 1 in 10 dads suffer from postpartum depression. And if a woman is in a heterosexual relationship and has postpartum depression, her partner is 4 times more likely to develop symptoms of postpartum depression.
Now that's fascinating because I've never heard of a guy talking about postpartum depression. And so that fact, 1 in 10 men in heterosexual relationships may experience postpartum. That's absolutely fascinating. Now, when you're talking about postpartum depression and you're thinking, you're a new mom, you're a new parent, how do you distinguish just being a new parent, I'm just tired, I'm tired of everything, to having actually postpartum depression?
That's an excellent question. So kind of what's the big distinguishing factor is when the mother feels or the dad feels like no amount of rest is going to ever, no amount of sleep is going to allow to make them feel rested. They actually feel like they could sleep for days and never be rested. Also, some of the behavioral things that sometimes we see, it doesn't happen for every parent, but also there's an impairment in the parents and child's attachment. So sometimes I have seen parents with crying infants, not crying infants that are crying because they're hungry or because they need a pamper changed or they want somebody to hug them, but an infant that is crying for 15 minutes plus and the parent is just totally checked out, not in tune to the baby crying. But also we're hearing feelings of shame and guilt over, oh my goodness, maybe my baby should have been delivered to another parent. Or, yeah, I really wanted this baby, or I may have prayed for this baby, but I don't like my baby, or I don't think that my baby likes me. One of the things that I tell individuals often is I work with a lot of depressed moms, very few suicidal moms. That's one of the biggest myths that's associated with this work is that these are individuals. A big myth is that if you have a perinatal mood anxiety disorder, that you're going to want to kill yourself or that you're going to want to kill your baby or that you are an unfit mom. And that is a big myth because yes, it is one of the features of postpartum depression, but everybody doesn't experience all of the same symptoms of postpartum depression. But that's what sets postpartum depression aside from just, oh my goodness, I'm overwhelmed, I'm tired, this is just oh so much. And what's also important is postpartum depression is not the baby blues. Baby blues happens within 24 hours up until 2 weeks after delivery. It occurs in over 80% of all women. And so, and that's the beauty of perinatal mood anxiety disorders. They wax and wane so quickly, so rapidly, and the turnaround time for treatment is actually pretty quick too.
Wow. So it sounds like, there's a chronic detachment from the baby, and either emotionally or physically, or an extended period of just being overwhelmingly tired. Yeah.
Sometimes some moms do have detachments and sometimes moms don't. One of the biggest things that I'm seeing lately as a result of this pandemic is an increase in birth trauma, which is significant because DC's Black maternal mortality rate is 10 times that the national average. So one of the things that I am seeing with the birth trauma is with postpartum PTSD is it's not a detachment from the baby, but sometimes a fear that the baby is not attaching to them or that they're not attaching to the baby, because some moms have had things like postpartum hemorrhage or preeclampsia where they were been discharged home for a whole week, and then they're starting to have the symptoms of postpartum hemorrhage and preeclampsia, and then they have to go back into the hospital for long-term just medical hospitalization to stabilize, recover, and recuperate, which means that the mom is not able to produce the breast milk that she would desire to produce to breastfeed the baby if she's electing to breastfeed. Not all moms are breastfeeding, but quick little fact here, pretty much formula is introduced to Black moms 10 times more than white moms in the hospitals. So, but still, and with all of that stuff that's going on there, let's say that like a mom does want to breastfeed and she's away from her baby in the hospital for weeks at a time recovering. She returns back to her baby. It's much more of this anxiety of and this guilt of, oh my goodness, like I thought I dotted every I, crossed every T, and I think I did the right thing, and I failed my baby, and will my baby love me? Will my baby know me? And it's hard because mom's literally fighting for her life, right? She's literally fighting for her life. And so she's coming home and trying to cope with pretty much fighting for her life in a community that's kind of like normalizing, well, you have a healthy baby, so why even worry about that? And it's kind of hard for her to kind of just recalibrate herself, or even calibrate. It's not even recalibrate, especially if you're a first-time mom. It's hard.
Yeah, I mean, just that description sounds very stressful, and it would require a lot of adjustment. Now, you mentioned the rate of introduction of formula and that. And so when we're looking at Black people, can you tell me about the prevalence of having this type of depression, and also any other anxiety disorders attached to that?
Yes. So
Sorry, I was
the
getting
statistic, I know it's all these terms. So the statistic, according to like Postpartum Support International, is like 1 in 6 and 1 in 7 moms are diagnosed with postpartum depression. However, for Black moms, it's 1 in 3. So when we also look at the number of also the maternal deaths that are associated with Black women as well, it's astoundingly high. So that's pretty much the prevalence there. And one of the things that grinds my gears is that we're not really discussing the correlation of these things. And I remember Dr. Ebanks taught me many moon ago, correlation does not imply causation. No. Okay, but at the same time that we are seeing that there is a correlation of maternal trauma and maternal mental health issues. And there is a reproductive psychiatrist, Dr. Alexis Lighton Wesley, who recently released an article in Blavity and Glamour that talked about the impact of Black maternal mortality and poor Black maternal health outcomes on Black maternal mental health.
Wow.
She's an awesome Black reproductive psychiatrist. She's just doing magical things. But honestly, to answer your question of the different types, so why I love working with perinatal mood and anxiety disorders is 1, wax and wane, turnaround time is pretty rapid, it can be. But 2, how they look as compared to our general major depressive disorder or our generalized anxiety disorder, or even what postpartum obsessive compulsive disorder looks like, as opposed to general obsessive compulsive disorder, is radically different. So I think the important thing to know is, whereas clients that I have seen with the disorders that I described, major depressive disorder, generalized anxiety disorder, or obsessive compulsive disorder, they will come to me and have come to me saying, things have just been different for a while. I just don't feel like myself. And sometimes I'll have clients where if I do an interpersonal psychotherapy inventory to try to assess when this has happened or when this begun, they'll say, I don't know. I don't know when this began. But for perinatal mood anxiety disorder, women are able to say, I started feeling this as soon as I got pregnant. I started feeling like this as soon as I delivered. Or especially for women that have undergone fertility treatments, I started feeling like this from the first test that I had to do to try to conceive. So we are able to pinpoint when the onset of symptoms have begun. For postpartum obsessive compulsive disorder, it's different than general obsessive compulsive disorder in that it has intrusive thoughts. So intrusive thoughts that can somewhat sound like hallucinations or voices. And it's a lot of behaviors that look scary to many individuals, but they also they serve to protect the baby, and it can be very confusing for people. The first time I had to work with a client that had postpartum OCD, thankfully I worked very closely with a reproductive psychiatrist, because it's very easy to misdiagnose, and I've seen moms be misdiagnosed with postpartum psychosis when it's just postpartum OCD. Because with postpartum obsessive compulsive disorder, and please pause me because I can talk about this all day, the mom actually has insight that these thoughts are scary. Like, I shouldn't be thinking about my baby in these ways. My cleaning obsessions are unrealistic, or me thinking that my baby has jaundice is unrealistic when 2 pediatricians have said that my baby doesn't have jaundice, as opposed to postpartum psychosis where the mom is just like, oh, these are my thoughts are fact, this is it. They're unable to really tell, hey, I'm here in Washington, D.C. on a Friday at 2:15 p.m. So those are the differences. But many people mistake postpartum depression for those latter two diagnoses that I was talking to you about.
Dr. Eagles has a question. Dr. Eagles?
Yes, you have made so many statements that I'm jotting down notes so I can, follow up and ask questions about. But, with your last point is that some people self-diagnose. Some people like, oh, this is, postpartum depression. And, I just need to relax. I just need to take a break. I just need, someone to help me with the baby. When you also stated that also within Black mothers, it's 1 in 3. How are you seeing that Black mothers are knowing what they're going through and able to say, I need help? And then how often are they seeking and receiving help? Because I have a whole list of questions regarding the healthcare system as well.
Yes. So it's interesting that you're talking about that. I'm pulling up a statistic that I had posted. So one, maternal mental health disorders, like postpartum depression, are the #1 most common complication of childbirth. And where's the statistic here that I had? Yes, Black women are less likely to be identified and treated for mental health issues during or after pregnancy. And that 1 in 2 women with depression during pregnancy are not treated. So to answer your question, I see moms that they just know that something isn't right. I'll be honest with you. More recently, as opposed to when I first started out doing this, more recently now today, I'm seeing moms that are like, oh, I know what this is. I've been reading about it and I want to get help. Especially prenatally, they're like, I now know that if I don't get help, this can contribute to maternal mortality. And I worked really hard to carry this baby throughout the whole pregnancy. I don't want to lose this baby. I don't want this baby to lose me, right? Whereas if in the beginning, when I first started getting into this work I've been licensed for 10 years, but like when I first started getting into this work about 5 years ago, I was seeing a lot, my back hurts, my shoulder hurts, my arms hurt from holding the baby, a lot of psychosomatic symptoms. Moms were much easier describing their mental health symptoms psychosomatically. And it was really kind of like, how dare you say that I have a mental health issue because I'm a good mom. So what I can say is, and more so recently, I've seen more acknowledgement because there's more discussion about it. Mm-hmm. But also, I cannot talk about this topic without giving a shout out to the doulas. I also hear more so from doulas that moms are much easier telling doulas at the home visits, I'm feeling very sad, I'm feeling depressed. And the reason why that happens is because the doulas are holistic. So the moms are kind of like, yeah, this is just a quick, easy fix. Tell me to drink some juices or something. And so I'm actually hearing a lot of my referrals come from doulas because it's doulas that they're in those intimate home spaces. Even during COVID, there are still some doulas that are doing home visits, even lactation counselors. And doulas are important because they help to minimize the rates of postpartum depression in Black women. They also help to minimize the rates of poor maternal health outcomes for Black women. So I'm seeing that Black moms are more informed and they are feeling a little bit more comfortable to speak up and advocate for themselves in the healthcare forum. I would love to talk about the healthcare segment.
Yeah, so it sounds as if also, I think with conversations like this and that, Brandon and myself and, Dr. Mack are bringing through the MECCA moments and, and also so many other platforms that are having these conversations around mental health and taking away the stigma that it's not about you not being a good mom because you're going through a period of postpartum depression or anxiety or, OCD after giving birth, whether it's after your first child or after your third child. This can occur at any moment. And it's not a reflection on who you are as a person, but the circumstances so I think conversations and making it more comfortable, as you said, for people to acknowledge that themselves and to seek, assistance, and to have individuals who specialize in this area, like yourself, finding your niche.
Yes, you taught us a lot about that.
Plugging in my, work as a professor.
I think it's interesting how your patients, your clients come to you, and they manifest their challenges in physical experiences, and you have the insight to translate the psychosomatic symptoms into mental distress or challenges. And I think that's great. And you mentioned doulas. We are mind body connected, and so that insight is good for people. You may just think you're in pain physically, but there may be some psychological distress, and I think that's a good point, because there are many factors that contribute to postpartum depression: environmental, biological, and it's good to have someone to help you, identify where the pain and the challenge is coming from.
Mm-hmm. Definitely.
Why is specialized therapy needed for maternal mental health? Why not just go to a therapist? Why do you need specialized attention to this issue?
There's so many different responses to that. One, graduate school doesn't require you to learn about perinatal mood anxiety disorders. Mm-hmm. Licensure boards do not require you to be well versed in this in order for licensure. It is important because I have seen clinicians that were not trained in this type of counseling, and even myself before I was, that when they do hear like the mom is feeling detached from baby, or the mom does not want to lift baby, or the mom is thinking about, that's another thing. I see a lot of people criticizing moms for wanting to extend their maternity leave during a global pandemic. Like when people see things like this, I've had clients that have come to me that have told me, I had a therapist that told me that I just need to suck it up and go back to work. And I know that I wasn't ready. And it's just like, you're absolutely right. You're not ready. Like you're having panic attacks every time you're looking at your work clothes, and you're having a hard time regulating your sleep. So I think that's why it's important. Your general therapist is not trained on the presentation of PMEDs. And I have, unfortunately, had experiences with clients that have come to me who just knew that something wasn't right, and they were seeing a prior therapist, and full on symptomatic. Like, and I actually had the opportunity to consult with prior treating therapists and just ask them, like, well, if you heard this, if you heard that, how come that didn't raise your eyebrow? Do you know how rapidly the symptoms of perinatal mood anxiety disorder can turn around? And so I'm glad that you asked that question, because postpartum depression, even how you speak to a parent and affirm a parent, is totally different than how you would speak to another individual. There's other things that you also have to take into account. You have to know the risk factors that places a person at risk for having postpartum depression. You need to be aware of what are some current somatic health issues that somebody has that can place them at risk for having postpartum depression. You also need to be aware of the type of medications that can trigger postpartum depression. So moms that are having issues with breastfeeding, they may be prescribed a medicine called Reglan. Reglan is documented. You go to Maryland Healthy Moms website there, and they'll have the medication chart, and it'll show you that Reglan is a medication that puts moms at risk for having postpartum depression symptoms. And also, a general therapist wouldn't be able to tell you the difference between femur or milk ejection reflex and how that presents differently from a perinatal mood anxiety disorder, because there are some somatic issues that can mask their presentation to look like perinatal mood anxiety disorders. And if you don't know that, then you can be treating not just, because when you treat a parent, you're treating the whole family, right? You could also also refer them to the wrong type of psychiatrist. So I only refer my clients to reproductive psychiatrists or reproductive psychiatric nurse practitioners because they are well versed in the hormonal changes that a mom goes through, or even down the line. I have clients that have come back to me that are advanced maternal age and they're going through menopause. Again, I would refer them to a reproductive psychiatric nurse practitioner. Your general therapist is not well versed in that, and they don't know that, oh, okay, like there is a psychiatrist that knows that these medications are harmful for pregnancy, or you don't need medication at all, or maybe we need to do some lab tests to see what's therapeutic, what's not, and to really just get the full picture of everything, to also simultaneously work in teams. Like I've worked in teams with, which have been fun, with a doula and a reproductive psychiatrist, and the conversations sound a whole lot more supportive, therapeutic, and than when I work with just the general population. And sidebar, when you go to perinatal mood anxiety conferences for professionals, there's lots of hugs and there's lots of, and it's very just it's a very professional community.
Mm-hmm. So with that, regarding families, because you said when you're treating the mother, you're treating the whole family. Mm-hmm. Can you talk about the relationships for the other parent, the partner, the father, perhaps? And you indicated that also a father may also experience postpartum depression. How is that different for the father in terms of how does that, is shown and demonstrated versus it just being relationship conflict, because now we have a newborn and neither person is sleeping and there's just stress level, of a crying infant, or a, perhaps financial, challenges, whatever it may be. How does that look different?
So what I was taught is that it looks different in that dad looks checked out, is not as emotional, is really just masking a lot of their emotional feelings. So me personally, I do not specialize in treating postpartum dads, but there are some local DMV therapists, very few that do. But my experience, because I definitely had a clinical experience with a client or two where I've said, hey, I believe both you and your partner are simultaneously experiencing these symptoms, and what it looks like for dad is not like, oh, I'm going to talk about how sad I feel and how detached I feel. It's really just like, hey, so yeah, the baby almost died when they were born. Okay, cool, but they're alive today. You're crying because you're healing from the C-section. All right, like, who cares? The baby's alive. You want me to get up and feed what? No, like, I'm trying to sit up here and make sure that I'm working. Again, we have a healthy baby. Why do you keep nagging me? Why do you keep talking to me? Why is it important that I have to be clued in and participating in a lot of these meetings for future child care? Like, why do I need to care? And when we actually take the time to talk to the mom about their pregnancy journey, this is the reason why I always like to ask about pregnancy journey. Then I start learning, either A, my partner went with me to my fertility treatments, or they felt really emasculated doing the fertility treatments themselves. Or what I have been hearing most recently is these traumatic birth experiences, not to scare anybody, but this is just really what's just been happening. Because even my interns, they have a couple of numbers of traumatic clients on their caseload. So we're seeing this. What we are seeing a lot of is the dad is literally an active bystander. I've heard experiences of individuals saying, well, my partner was made to feel like they had to have more experience than the treating doctor. Actually, and that's the other thing that individuals are not talking about. It's not just a birthing mom that is in that delivery room. Even if you let's have a surrogacy and you're in a same-sex couple, that couple is also in the room watching the mom go through all medical trauma that's happening and watching all the chaos that happens in there, and sometimes having to be a part of the decision process if they have a doctor that practices and believes in consent that we're legally supposed to have, or if you don't, right? And so we don't talk about the powerlessness that the partners feel when they're watching their whole family just pretty much be under duress, and then nobody's talking to the partner about that when they go home. Like, what was it like to, and I'm sorry to be very graphic, but what was it like to see your partner flatline? What was it like to see them be revived? And then what was it like to see them bring your baby to the NICU? These are real conversations. These are real conversations that are not happening. So as a result of nobody checking in, and especially if dad is working at a place that doesn't have paternity leave, so he now has to leave the baby, leave the partner that he just feared like for his life of, oh my gosh, what we're gonna have. It's kind of, there's a lot of masking. There's a lot of masking, and there's a lot of resentment, and sometimes fear, sadness can look like anger. Yeah.
That's fascinating, because as you're speaking, I got a new awareness. You don't really talk about those events. You go to the hospital, you have a baby, whatever occurs in that room, you move on after the fact. And there could be vicarious or secondary trauma that lingers and never be discussed. And so I thank you for bringing up that making us aware that things happen, and you need to sometimes talk about it, and it can impact your relationship with your partner and your child. So thank you for that awareness.
And along with that, that conversation, it goes back to the healthcare.
Yeah.
And there, the rate of death of Black women as a result of childbirth is significantly higher than any of their counterparts. So now you potentially have a mother that might have passed, and now the father or the parent may be, other partner, may be now responsible, for caring for that child. So they're dealing with the trauma of losing their loved one, their partner, and now seeing, having to care for this child that they were not prepared to do alone.
Yeah, it's very real. And I feel like, I feel like the best way to have the analogy is, make pretend that there's a couple, right? And there's a house fire. Universally, everybody's going to check in with both people. Are you okay? Are you all right? I know that had to be really tough. Do you need anything? Both people in that relationship are going to check in with each other, because it was like, oh, we went through a fire together. But once we start talking about birth trauma and mental health, society, everybody's not checking in with both people at the same way, at the same time, to say, are you okay? How are you doing? And again, in the same breath, like, we have moms that are living. We do have moms that are living, but like I mentioned earlier, they've been away. They've been away. I mean, I've heard of moms' bodies doing things I didn't even know was possible, okay, just to save the baby. And but they have to go back into the hospital to recuperate. And it's kind of like, not kind of like it is, it's just really tough for two people to manage trauma. And I also talk about this a lot with infant loss. There are moms that are living through these traumatic births, but they're not coming home with babies, right? And so a lot of how each person responds to this experience sometimes is also influenced by their own personal histories of loss. And that's one thing that they train perinatal therapists to talk about, is like, okay, what was did their clients' parents suffer from perinatal mood or anxiety disorders or infant loss? And I have seen recurrent themes of how, like, the family of origin has dealt with infant loss, and then how that's looked like in terms of care or lack thereof on the client that has had an infant loss themselves, or been able to relate with their partner. Because, today we have blended families. So we do have partners that may have experienced traumatic births or pregnancy losses in a prior relationship. And so they're coming into this relationship with their own prior histories. And so it's a whole lot of clinical work to be done here.
We're talking a lot about postpartum, but how important is maternal mental health? in preparation for having a child?
It's so important. It's so important. One because many women who have bipolar disorder are first diagnosed perinatally. Britney Spears was an example of that. But so it's important to, and also the risk factors. So for individuals that have had a prior history of any type of mental health issues, especially sexual trauma, there's a higher likelihood for them being at risk for having a perinatal mood and anxiety disorder. And so it is important to go to therapy ahead of time. I mean, especially if somebody's had a prior history of sexual trauma. I've had sessions that have had to center around, okay, mom wants to breastfeed, but due to her prior sexual trauma, she wants to process what that experience is going to be like for her. Or even, again, trying to deal with, that's why there are some perinatal therapists that also specialize in EMDR, eye movement, desensitization, is it relaxation, Dr. Ebanks?
Yes.
Yeah, so but in any event, it's because they're just the whole concept of, yes, I want this baby, but I have to be in stirrups and to have these strangers pretty much helping to deliver my baby. And that's nothing else I wanted to mention here as well. While I have the platform to mention, I hear many times from Black moms saying, oh, I'm only going to use a midwife. I'm not going to go to a hospital because these are the things that are going to reduce my maternal mortality. I want to make sure I say this all the time because I recently learned of this because I'm of advanced maternal age myself, which is you can be 40 and 42 years old and be a low risk pregnancy. And you can, and honestly, but if you are 35 or 25 or 45 with a high risk pregnancy, you really do want to ask about the limitations, the capabilities of a midwife, because a midwife can only do vaginal births. And if you're a high risk pregnancy, does that really make sense for you to be partnered up with a midwife? And these are the kinds of things, the education that we need to get when we're talking about reducing maternal mental health rates and reducing maternal mortality, because this is why therapy is important. Whenever I have moms that come to me that are thinking about conceiving through fertility treatments or just conceiving, I always encourage them to meet with a reproductive endocrinologist. And I do referrals to those types of docs and reproductive therapists because we need to understand that sometimes our somatic health does influence our maternal mental health. And it's okay to jump in front of our maternal mental health by recognizing and learning more about your somatic health and the things that can place you at risk for having maternal health issues, which can then produce maternal mental health disorders.
Siobhan, it sounds like not only do you need to have a plan for preparing to have a baby in terms of, going to classes, but you need to have sort of like a mental health plan for pre and post, because I mean, just hearing you talk, there are a lot of things, concerns, conditions, challenges that may impact your mental health before and after having a baby.
Mm-hmm.
Yeah, and again, the other reasons why, like untreated maternal mental health disorders, also they don't cause, but they are connected to higher instances of behavioral health disorders in children down the line. It can also impact, again, parent-child attachment. Untreated maternal mental health disorders are also linked to preterm labor, low birth weight babies, NICU babies, and I'm trying to think, what are some of the other, there's so many. And again, postpartum birth complications. So I always, my first line to go, especially with a pregnant mom, is to begin to start looking at ways to relax, ways to start developing healthy coping skills. I hear oftentimes that like we're in a pandemic, that's even more reason to learn how to have a healthy toolbox of coping skills prenatally in postpartum, so you can equip yourself and protect yourself and protect your baby as best possible. So, yeah, I mean, I also do like brief consults. Sometimes I have moms that just meet with me one time because they just want to know what's going on. Other quick fact, all OBs and all midwives and all doulas are supposed to screen moms. Oh, and pediatricians are supposed to screen moms for postpartum depression once every 3 months prenatally. And then when you deliver, you're supposed to be screened at your well child check and then at your 6-week postpartum visit. So you can be screened right on this visit.
It really sounds like you need, like mothers should consider at every stage, because even prior to conception, if they're having fertility issues, if there's a history of mental health disorders, and certainly during the pregnancy, because there are some health conditions that may arise as a result of the pregnancy. I was watching one of the episodes of Black Love, and there was I can't remember the name of the actress, but she was stating that her pregnancy, it wasn't just the first trimester of nausea. It was the entire 9 months of the nausea, and it was repeated, nausea that led her to not be connected to the pregnancy, because of the result that she was just not feeling well at all throughout her pregnancy. And immediately after giving birth, she was fine. So it's difficult. She indicated it was difficult for her to, she loves her son, but it was like, how am I going to feel like, because for 9 months, it was very traumatic physically and mentally on her. She was exhausted. And then afterwards, it was instantly just gone. So even someone like that, just that transition, of becoming a mother, could, certainly be a time where they need counseling as well, even if they're not having symptoms of postpartum depression or postpartum anxiety.
Mm-hmm. You're absolutely correct. And actually, the best therapist for women that are going through fertility treatments, sometimes outside of a perinatal therapist, is a reproductive therapist. That might be my next certification I'll work on. And they even have reproductive doulas. So doulas that just help you through the whole process of fertility treatments. And they're very helpful, very helpful. So I definitely believe it's never too late and it's never too early to get a checkup from the neck up.
A checkup from the neck up. I think that's a great phrase to remember for all of us. Okay, so before we end pretty soon, let's talk about the risk factors one more time. I know you've sprinkled it in between, but risk factors for postpartum depression and maybe even go into some anxiety challenges.
So I hear you talking about postpartum anxiety. So postpartum anxiety also has a high prevalence too. It's not really discussed as freely, but here in our wonderful nation's capital, I definitely see postpartum anxiety more so than I see postpartum depression, because we have a lot of successful women in our nation's capital. So they're used to being in control and making the key decisions for a lot of things. And so birth doesn't quite work like that. But some of the implications of just untreated postpartum depression or postpartum anxiety, which again you can experience prenatally, is again just low birth weight baby, preterm birth weight, low pregnancy weight. And like even the baby can be small for their age. And the first time I saw this, I literally had to tell myself, this is not made up. This is real. Your eyes are not like fooling with you. I actually saw, and brace yourself for this, a 2-month-old 5-pound baby. They were not a preemie, right? And fortunately, this person had a visiting case manager, and they were very closely linked up with their health insurance. And I immediately called their insurance care manager, and she's like, are you aware that this? So I'm just saying that. So that's very real implications that can happen. one of the impacts too is if you're in a relationship. I mean, it could definitely impact somebody's romantic relationship. So the other suggestion I would also have too, because I've been seeing that there's been a wonderful rise in COVID babies. If you're in a COVID, developed relationship, definitely make sure that you're going to get the couples counseling that you need even during the pregnancy, because those are things that can definitely impact mental health.
Yeah.
And what's a tip or two that you could give a family member, a friend, or a partner, or the father of the child to help a mother that's in need? What's a tip or two that you can provide?
Do not let your health insurance or lack thereof be a barrier for you seeking out mental health counseling. Yeah, here in the DC, there's a free clinic called 5 Trimesters Clinic. It's based out of George Washington University. It's grant funded. And why I like 5 Trimesters Clinic is because they have teams of therapists, and different level therapists like counselors, psychologists, social workers. But they also have OBGYNs, and they also have reproductive psychiatrists. So when you go, and the other thing for those of you that may be just learning about this for the first time, it's not meant to be long term. So when you go to GW, you're probably there. Like when I say there, like it's an outpatient clinic. You're going to, your appointments for maybe 90 days tops, if that, because the treatment is so comprehensive. And so they do not require you to have insurance. And so they also do sliding scale. So there are lots of individuals that are going there and getting services for free. So I believe it's an underutilized resource in the African American community. And also, you want to learn more, like myself and Mary Center are putting on a conference for perinatal mood and anxiety disorders November 9th. To just talk about just the state of maternal mental health in the District of Columbia.
Oh, excellent. Thank you. Can you please, share that with me? And I will certainly put that on our page as well. All of those wonderful resources. And again, that's one of the reasons why we have the MECCA moment, is to have conversation, provide information, and provide resources for anyone in need, or if you know of someone in need of this information.
Absolutely. Thank you so much, Siobhan, for just sharing all of this information. It's been eye-opening for me, definitely, and I'm sure for all of those out there who are watching, definitely eye-opening. And I appreciate you mentioning that sometimes the financial barrier may appear to be real, and it is very real, but there are resources out there for everyone. It just takes a little searching and support and information from people like you. I feel like I'm doing PBS.
Make a donation. Yeah.
Yeah. But definitely, it's out there, and that's what MECCA Moments is about. Is really putting that information out there and helping people see that they aren't alone and there is support available. Dr. Ebanks.
Yeah, and so thank you, Ms. Odom, Ms. Siobhan Odom, for the work that you're doing out in this community, the information you're providing, the services you're providing to a much needed population. So thank you for that. Thank you for taking the time. Brandon, thank you again, once again, for being such a gracious host. And again, the MECCA Moment is on the second and the fourth Friday of every month. Next, in 2 weeks, we'll see you to talk about co-parenting and how to continue working effectively as co-parents to raise, children. Remember to vote on November 3rd. Please remember. And today is also National Daughters Day. So, my daughters.
Hi.
Hello. Hi. So Love on your children, love on your friends, love on your partners. As Savon said at the conference, everyone's hugging and, just embrace each other, because certainly during this time of the pandemic is certainly a time to appreciate friends and family. So
Absolutely.
thank you.
All right. We'll see
Thank
you guys in 2 weeks. Thank you so much, Siobhan, for talking with us.
Okay. Bye-bye.
Thank you. Bye.
Bye.